Namaskar and a very warm welcome to this edition of our program, Let's Talk Health Nephrology Queries. I'm Nidhi Kumar and you're watching India Science. Friends, as COVID 19 continues to surge in the country, COVID related queries are on the go. People are speculating about health problems, and we get you queries on kidney health today. In this program, where we take your questions from Facebook and YouTube Live, we are joined by the very well known Dr. Arunkumar S, Assistant Professor, Department of Nephrology at the All India Institute of Medical Sciences, New Delhi. Namaste, and thank you so much for sparing your valuable time to be with us at India Science today.
Namaskar, ma'am. Good afternoon, and thank you for having me here today.
Many thanks once again for joining us. I begin with my first question, which is please tell our viewers about the current nephrological scenario in India as far as the disease is concerned in view of the new strains. How do you prioritize hospital management in such times? Is there any specific protocol that you're following?
Ma'am, the very first time COVID had started a couple of years back, they were very unprecedented times. We didn't know how to act at first because almost all the entire outpatient departments were closed. Inpatient admissions got blocked because there were no beds apart from for COVID patients. These were these scenarios in the first two COVID waves. However, thereafter, our understanding of COVID and the way we manage COVID has changed over the last couple of years. So, at present, the cases of COVID are increasing, as you have well pointed out. And for this, we do monitor patients. Like any patient who gets admitted gets a COVID test done first before admission. Any patient who has a symptom of COVID, right now the most common symptom being fever with some sore throat, throat pain, throat ache, or some mild cough, we evaluate them for COVID otherwise. Apart from that, the standard precautions are followed. Our routine OPD, outpatient department management, is being continued, and the management of nephrology diseases in general for all other diseases are continuing without any problems at present in this present COVID wave. Compared to the earlier waves, this wave has been slightly mild till now, probably similar to the Omicron wave which we saw in January. However, it is too early for us to come to a conclusion. We should not let our guard down, and as always, we need to make sure that we carry out the entire precautions at home. So we ask our renal patients, especially those who are on immunosuppression, like those who are having inflammation of the kidney, the glomerulonephritis, or those who are transplant patients, those who are immune-mediated patients like lupus. We ask them to maintain an extra care when they go to common places, even when they come to OPDs. As always, the standard precautions of masking and sanitation does help to prevent COVID even in our patients.
Right, doctor. Now, coming to kidneys, how do you keep good kidney and health?
Uh, as kidneys, the most important function of our kidneys is to filter our blood. So it filters the blood, it removes all the waste from our body, and you'll be amazed to know that more than 150, nearly 180 liters is being filtered by our kidney every day, and out of that the kidneys tend to reabsorb most of it, and only a part is secreted as urine, around 1 to 2 liters per day, which varies according to the patient and water intake otherwise. So kidneys does this function is what we all think of, that this is the only function. But apart from this, we should remember that kidneys also has other function. One, it produces a hormone called erythropoietin, which is required for normal hemoglobin production of the body. It is involved in activation of vitamin D, which is needed for bone health and general health. It is thereby it affects the parathormone levels, which also affects bone health of our body. So when the kidneys are functioning optimally, bone health, hemoglobin, and general excretion of all the nitrogenous waste happen properly from our body. So the best way to maintain kidney health is to maintain general health. I think this is a standard rule for almost all chronic diseases or all diseases of lifestyle. Even kidney per se has become a lifestyle disease because the most common cause of kidney disease is either diabetes or hypertension. So if you're going to maintain a good health, the kidneys health are maintained. So in addition to that, a certain other pointers would be that you should maintain an adequate water intake, because you can't stress the kidneys by having a lesser water intake daily. So what is adequate would be the next question. There is a general notion that having 8 glasses of waters per day is good for the body. There is no quantification of 8 glasses, but overall, around 1.5 to 2 liters per day is a good water intake or an optimal water intake for patients without kidney disease. So there are some patients with certain types of kidney disease wherein the water intake has to be increased or decreased. It is decreased for those with renal dysfunction, that is when the creatinine increases. It is increased for certain diseases like some types of calculus disease and some types of polycystic kidney disease. For these patients, we tell more water intake has to be taken. Apart from that, all other patients can take in around 1.5 to 2 liters of water per day. One. Apart from this, there should be a normal lesser salt intake. What is recommended by the World Health Organization and most of the health organizations is 2.3 or 2.5 grams of sodium per day, which accounts for 5 grams of salt, 5 to 6 grams of salt per day. This is good for both to maintain kidney health, to make sure that your hypertension is in control, and takes care of almost all the metabolic syndrome associated lifestyle diseases also. We
Right,
have
doctor.
to.
We'll come to the diet and the health part of the intake a little later. Meanwhile, I want to ask you, what are the warning signs of a kidney infection? If you could share that with our viewers.
So, the earlier stages of kidney disease. So, kidney disease goes through a number of stages. The earlier stages is where the creatinine may still be normal. At this stage, there are usually no symptoms. It is usually subtle symptoms are there. Patient would just feel some amount of fatigue, some tiredness which is not explained by not resting well. This fatigue is the most common reason which makes the patient come to the doctor to search for a cause. Usually, we see that anemia is a very common cause of fatigue, but you'll be amazed to know that any chronic disease can cause fatigue, and CKD is one of the most common thing. Apart from this, the other warning signs are when when the patient is going to have swelling in the feet, what we call as edema. The earliest swelling happens around the eyelid. So this is usually happens when the patient gets up in the morning. They seem to have puffy eyes, and as they pass through the day, it gets better, and people usually tend to think it is because of lack of sleep or reduced sleep. But this can be one of the earliest signs of kidney disease. At present, at times the patient can have frothy urine, that is froth in the urine. This happens because of excretion of excess protein in the urine. This is also a sign of kidney disease. Patients can have blood in the urine, which is called as hematuria. It happens in certain inflammatory kidney disease like glomerulonephritis as well as in urinary tract infections. And in later stages, patient will start having itching of the bodies, very severe fatigue, severe anemia, and other complications because of kidney disease, including cardiovascular disease. In the earlier stages, it is only fatigue, reduced output, uh, frothiness in the urine, blood in the urine, and a general evaluation for those who are already at risk for kidney disease, like patients with diabetes or hypertension.
Right, doctor. You mentioned types of kidney disease. I think we'll talk in detail about CKD a little after this. But roughly and broadly, what are the kinds of kidney diseases?
So this is probably a very important question for the patient point of view. The patients usually ask us whether my kidney disease is going to get cured or not. Or I had a relative whose kidney disease got cured. Why is mine not cured? So for this, we need to understand what are the various types of kidney disease. The first one would be something called acute kidney injury. As the name suggests, acute. Acute means it has happened in the short history while. There's a kidney injury which happens due to multiple reasons, which include infections, including COVID, dengue, malaria, urinary tract infections can cause, because of generalized sepsis, because of pancreatitis, because of burns, because of a general health condition, the kidney health can get affected. And once you treat the general health condition, once you treat the infection, the kidney health normalizes. This is what is acute kidney injury. It is usually reversible. If it is very severe and requires dialysis, it is reversible in around one third of the cases. In the other patients, it can progress on to chronic kidney disease. This is acute kidney injury. This is the first type. The second type would be chronic kidney disease per se. As the name suggests, chronic. So it is there for more than 3 months. So in this, patient who has had any history of renal disease for more than 3 months constitutes chronic kidney disease. So most of the time, patients present to us directly with kidney problem, and we have to diagnose CKD based upon certain other factors like anemia, hyperparathyroidism, which happens in chronic kidney disease, are silent markers by which we make it as CKD. CKD is not reversible. We only reduce the speed of progression of CKD. This is the major chunk of patients what we see. The third one would be glomerulonephritis. There is glomeruli is a major part of the kidney, minor part of the kidney, which forms the filtration function. So when the glomeruli has a inflammation, it is called glomerulonephritis. In this, patient presents with urine, blood in the urine, or protein in the urine. We diagnose this by doing a kidney biopsy. So this is a case in which kidney biopsy is done. Based upon the biopsy findings, we tend to give therapy, which is usually a combination of immunosuppressive, which is given. The fourth type would be renal calculi disease, where patient tends to have stones either in the kidneys or anywhere in the urinary tract, either in the bladder, urethra, or the ureters. So this can also cause renal problems. Apart from this, we have something called acute kidney disease, which is something between AKI, acute kidney injury, and chronic kidney disease, which is probably till 3 months duration of a renal problem. So, for all practical purposes, acute kidney injury is reversible, chronic kidney disease is not. Glomerulonephritis would require a kidney biopsy and would require immunosuppressive therapy. These are the major classes of kidney diseases.
Doctor, you mentioned CKD, and what are the complications perhaps that you can have in CKD, and what are the stages of CKD? Is it done in stages, or is there even a treatment for CKD?
Oh, I think that is probably a very clinically important question for patients per se. Chronic kidney disease, it is chronic, so it is going to progress in stages. In the earliest two stages, the creatinine is the marker by which we measure how much of the wastes are present in the blood in patients with kidney disease. So in the earlier two stages, stage 1 and 2, the patients can still have a normal creatinine. So only those who are having protein leak or who have earlier known that they are having a kidney disease, we try to catch them in these stages. Otherwise, clinically, when the patient presents to a nephrologist or to any physician, he presents from stage 3 to 5. So, what we measure from creatinine is something called a glomerular filtration rate. Patients tend to ask what percentage of my kidney is functioning. So, this percentage, we get it from the creatinine by a formula, or we can directly measure it used by a DTPA scan. So, by measuring this, we come to numbers. The normal renal function is more than 90%. In the first two stages of kidney disease, it still stays more than 60%. That is, a GFR stays, glomerular filtration rate stays more than 60, because of which it cannot be diagnosed by only using a creatinine. But if we measure the GFR, which depends on the patient's age and creatinine, we can diagnose these stages too. In stage 3, the GFR is between 30 to 60. Roughly speaking, 30 to 60% of the kidney function is there. In stage 4, GFR is between 15 to 29. That is, kidneys function for by between 15 to 29% of the optimal number. In stage 5, kidneys function less than 15%. After stage 5 is 5D. 5D means dialysis dependent stage. Usually when the GFR drops lesser than 10, or if the patient tends to have symptoms of severe chronic kidney disease, uremic symptoms, what we call, because of increase in urea, like patient will have nausea, vomiting, will not be able to have complete loss of appetite, has loss of muscle mass, because when the uremic solutes are increased in CKD, there is acidosis, which in turn eats away the muscle of the patient. The diet is affected. Then the patient has to be initiated on dialysis. That comes to the stage of stage 5D. So these are the 5 stages of CKD. Practical purposes, 3 to 5 is a stage. Most of the patient present to us in stage 3 or 4. We make sure that there is progression of CKD is slow. That is, we cannot cure CKD per se. It does not have a cure, but we can reduce, slow down the progression of chronic kidney disease using some drugs. For patients who are having hypertension and proteinuria, we can use a class of drugs called AC inhibitors or ARBs. Common drugs being ramipril, enalapril, and telmisartan. And apart from that, we have a newer class of diabetic drugs, anti-diabetic drugs, which also reduces the progression of chronic kidney disease. This is called as SGLT2 inhibitors. The most common drug which is available in the market is dapagliflozin. These are some of the drugs which reduces the progression of chronic kidney disease. Apart from this, we try to measure the bicarbonate levels in blood. We measure the calcium phosphate, vitamin D, and PTH levels in blood. All these tend to get affected in CKD. By measuring their levels, we try to optimize their management with appropriate drugs, which therefore reduces the progression of chronic kidney disease.
Right, doctor. How does one test for a kidney function? What are the kind of tests available per se in the hospital or in the labs?
The two major sources would be blood and urine. So, an easier method or a screening test would be a urine test where we can look out for leak of protein or leak of blood in the urine. That is whether there is proteinuria or hematuria. This can be done by doing a simple urine routine microscopy or by using a dipstick test, which is available even in primary health care centers across the country. And apart from this, we most common way to diagnose CKD would be through doing a blood test. By doing a blood test, we measure urea and creatinine. So urea and creatinine are the waste which are produced from day-to-day metabolism of our body, which is excreted by the kidneys. So when the kidneys are functioning suboptimally, they tend to get accumulated in our body. So if at all urea and creatinine start increasing, we should suspect that the patient is having a kidney disease. Now, apart from this, kidneys are responsible for excretion of potassium and phosphorus also. So, in patients with kidney disease, potassium and phosphorus would also be increased. So, we will have to give drugs so as to control these. This is because phosphorus, when it is increased, it can affect bone health. Potassium, when it increased, can affect cardiac health. So, that is why we need to monitor them. Apart from this, we need to measure bicarbonate levels in the blood. Kidneys are the ones which maintains the acid-base balance of our body. So again, when the kidneys are affected, the acid load of the body increases and the bicarbonate, which is alkali, reduces in the body. So we have to measure it, and if it is less, we need to substitute it. Patients with kidney disease, as I told earlier, erythropoietin is produced in the kidneys, which is needed for anemia, hemoglobin production. In kidney disease, this does not happen, and patients with CKD will tend to have lower hemoglobin. So that is why we need to measure the hemoglobin levels of patients with chronic kidney disease, and if that is low, we give erythropoietin supplementation in the form of injections for these patients.
Right, doctor. Very well explained. Could you also tell us what is ESKD, that is end stage kidney disease, and
Yeah.
how does one
So
know whether you have it?
So we spoke about the stages of CKD. CKD stages are from stage 1 to 5 based upon the GFR. So when the GFR is less than 15, it is called as chronic kidney disease stage 5. So when these patients develop symptoms of uremia, as in, about nausea, vomiting, itching, and the GFR drops even further to less than 10, then we call it end stage kidney disease. That means the patient has reached the last stage of kidney disease, wherein he will require renal replacement therapy. As the name suggests, renal replacement. So we try to replace the function of the kidneys by giving some therapy. These are two types of therapies: dialysis or transplant. So any patient who requires either of these therapies is told to be in end stage kidney disease. So we know this by measuring the creatinine and calculating the GFR in patients with kidney disease.
Right, doctor. Could you explain for the layman what is a kidney transplant?
uh, Patients with end-stage kidney disease or with very much reduced renal function, uh, the kidneys are not functioning. So the kidneys function has to be replaced, or something else has to do those function. Dialysis does remove some of the waste of the body, but it does not take care of the other functions of the kidney, namely production of hemoglobin, activation of vitamin D, bone health, and overall anything which is artificial is not going to replace a natural function any day. So the only way this can be bypassed is by taking a kidney from another human being and placing it in the patient with end-stage kidney disease. So this process where you keep a new kidney in a patient with end-stage kidney disease is called kidney transplantation. There are multiple
And
types. Yes, ma'am.
yes,
There
yes.
are multiple types of kidney transplantation based upon the
How
type of.
effective is a kidney transplantation is what I want to ask you next.
Okay, so based upon the type of the donor, the person who gives the kidney is called as a kidney donor. So based upon the type of donor, we divide kidney transplantation into living and cadaveric. Matlab, as the name suggests, living means it comes from a live related donor. So in India, according to the laws, a live related person can donate the kidneys to a patient with ESKD. The common donors in our country at present include parents, siblings, and spouse. These are the most common cause. If at all for some reason they are not able to give for some medical reason, then the near relatives can be a source of potential donors. So as a normal human being tends to have two kidneys, one kidney can be taken from a normal human being and can be placed for a patient with kidney failure. In this way, both the donor is also not affected and the kidney and the recipient, the one who receives the kidney, is also happy, can function optimally. The other donation is the cadaveric donation, wherein patients who are either brain dead following any brain insult or RTA, the road traffic accidents, or having a cardiac death. From them, we can obtain the kidneys before declaring death, and it can be transplanted into a patient. This is called a cadaveric donation. There are multiple government schemes that are going on to promote cadaveric donation also, but at present, living donation is the most common source of kidney transplant in India.
Right, doctor. Could you also explain before I go on to the other kinds of transplant? There is something called a preemptive or a early transplant. What is that, doctor?
So, by a preemptive transplant means, as an English term suggests, preemptive. So, before the patient requires a transplant. So, as we had discussed, patients with chronic kidney disease stage 5, they are the ones who would require renal replacement therapy. They are the ones for whom the kidney function is not optimal at all, and they require a replacement. So, they require a kidney transplant for sure. That is a normal kidney transplant. If at all we do a transplant even before the patient goes into stage 5, that is when he is in stage 4 itself, consider that the GFR, the glomerular filtration rate, is borderline, or before the patient develops symptoms of chronic kidney disease, CKD 5D, then it is called as a preemptive transplant. So it is done before the initiation of dialysis or even before the stage 5 of CKD sets in a patient. If you do transplant, it is called preemptive.
Right, doctor. Now, could you specify for our viewers who can get kidney transplants? And can you take it from a relative, like you mentioned, who's older but has some health issues, maybe some complications? What happens in that case? How does one go about getting a kidney transplant?
So, in general, any
It's not
adult,
easy. It's not easy.
it is not easy. It is not easy because there are some rules. Because for us, the donor is very important. So even after kidney donation, the donor has to live a healthy life. So there are multiple health checks for the donor to ensure that even after kidney donation, the donor has a near optimal or a near normal life forever. So we have certain conditions which the donor has to fulfill. It has to be an adult, 18 years to 65 years of age. Up to 65, kidney donation is accepted. They can have hypertension, but it should be well controlled on one drug, and there should not be any end organ damage. That means patient who is taking only one drug for hypertension for BP control without damage to the heart, eyes, or to the kidneys can donate kidney. If at all they require two drugs or the BP is not controlled, then we don't take kidneys from them. Diabetic patients cannot donate kidneys. Apart from this, anyone with a known history of kidney disease cannot donate kidneys. So these are the standard laws which we follow so that the donor health is preserved. With the question of who can donate, uh, any first degree relative, that is parents, siblings, spouse, they are the ones which who are the most common source of donation. Apart from that, if at all medical for the above mentioned reasons, if they cannot donate, then the second degree relatives can donate after approval from the transplant committee in the concerned hospital. So only related donation is at present legalized in India.
Right, doctor. And tell us also about what if the body tries to reject the new kidney? How often do these rejection episodes happen? And what are anti rejection medicines?
Uh, the kidney transplant, it is a complex process in that we are keeping a foreign organ. Whatever said and done for our body, the kidney which is kept is a foreign organ. So whenever there is something which is foreign to the body reacts to it by producing antibodies against that organ. So we try to reduce these antibodies by giving immunosuppression. So we suppress the immunity of the recipient so that the kidneys are accepted for the patient. Of all the organ donations, the most successful donation is a kidney donation. Still, the success rate is around 90%, even in the best of best centers. That means that this does not mean that 10% fails. It just means that 10% can have some amount of rejections. And to manage this rejection, what we do is we try to increase the immunosuppression so that the body is able to accept the kidneys. This anti-rejection drugs can be steroids, high doses of steroids. It can be ATG, anti-thymocyte globulin, which is an injection. We can do plasma to remove the antibodies in case antibodies are present. And apart from this, all transplant patient receives three types of drugs. One, steroids. Two would be a calcineurin inhibitor, commonly called as tacrolimus or cyclosporin. And three, an anti-proliferative agent, which is called mycophenolate mofetil, MMF, or azoran, azathioprine. So these are the three classes of drugs which are continued in transplant recipients lifelong. When they have rejections, we usually give injectable immunosuppressants in order to preserve the kidney and protect them from further injury.
Right, doctor. We have a caller, Navneet Ji is joining us. He's asking, why is the old kidney not removed? And could you share what happens to the old kidneys, doctor? Is it removed or it is not removed? That is the question.
Uh, the old kidneys are not removed in more than 95% of the cases of kidney transplant. Only in cases where the old kidney has had repeated infections, there is probably a reflux of urine into the kidney and it can get repeatedly infected even after transplant. If the kidneys are very big, which can happen in patients with polycystic kidney disease, which is a type of kidney disease, inherited genetic disease, in that the kidneys are too big, old kidneys, because of which there won't be space to place it. In only in these conditions we tend to remove the old kidney. Otherwise, the new kidney is placed in a completely different location. It is placed in the anterior part, that is in the front part, whereas the old kidneys are in the back part. Because they are placed in a completely different location, there is no need to remove the old kidneys unless and until for these two couple of reasons, where the old kidney, if it stays back, it can give problems to the new transplant kidney or to the patient. Only in these cases it is removed. And basically it is again a major surgery. So we don't, and no major surgery is done without a need or an indication. So there is no indication, we don't remove the old kidneys at all. The new kidneys are placed in a completely different place.
Right, doctor. The next question that we've been asked this time by Payal Ji is, does kidney transplantation affect sleep and fatigue in patients with kidney disease?
Yes, fatigue is the most common symptom in patients with kidney disease. This is not only because of the waste which accumulate in the body, it is also because of the anemia which happens in kidney patients, reduced hemoglobin also. And moreover, whenever the wastes are more in the body, when there is acidosis, the patient tends to have a generalized fatigue always. And when the patient has a non-specific fatigue, it tends to affect the sleep of the patient. Most of these patients tend to have poor nutrition also. When there is poor nutrition, again the sleep gets affected. So these are the combination because of which sleep is affected in these patients. In later stages of kidney disease, patient will tend to have some amount of water accumulation. When water gets accumulated in the lungs and all, the patient will have difficulty in lying down. This also tends to affect sleep in these patients. There can be blood pressure fluctuations because of the way the drugs react in a failing kidney. This will also cause sleep fluctuations. This is quite common, and both sleep abnormalities and fatigue, it affects the quality of life in patients with CKD. So that is the reason why we try to manage each and every of these parts separately and probably do a transplant in order to improve these conditions for the patients.
Right, doctor. Since we're running out of time, one last question to you. This time, this comes from Shubham. She wants to know, minor infections such as urinary tract infections, colds, and flu are common after kidney transplants, right? Potentially more serious infections such as pneumonia and cytomegalovirus, CMV can occur and may require afterwards, hospital treatment. Is this true?
Yes, it is true. As the kidney transplant patients, they are usually treated with immunosuppressive drugs because they have to accept the foreign organ. So they are given drugs which reduces the immunity. So the consequence of that would be that they are at a higher risk for infections. But we should remember that the immunosuppression is at a higher level in the initial few months of transplant. After the first few months of transplant, if the patient's kidneys are functioning well, we tend to reduce immunosuppression. And after a point of time, the risk of infection is nearly as normal as a normal individual. But we should remember that they should always take extra precautions when compared to the normal patients to prevent infection.
Right,
Most
doctor?
of these. are
Yes.
manageable. So I don't think infection should be a deterrent for transplant at all. They have not been a deterrent, and they wouldn't be a deterrent also.
Any new methods coming up in the near future? I'd like to end on that, doctor, for dialysis. Anything advanced, anything that is now coming up in
Uh,
India? Would you like to share with our viewers on India Science?
yeah, one thing is that there is something called artificial kidney, which has been developed in United States of America. One, there are some trials which are going on for it, which probably in the next few years, probably 5 to 10 years, it may make things easier for patients, at least for those who don't have a donor for kidney transplant. Dialysis services has improved vastly across the country with the new plans. The access to dialysis has improved. There is a new peritoneal dialysis program which the government would be approving, following which it may become easier for patients to access dialysis across the country. Transplant drugs have evolved. We have better drugs now, because of which the lifespan of kidney transplant has improved vastly. There is a new injectable drug which may come into the market shortly, which can also improve the outcome in transplant patients. So there are developments which have happened, and over the last couple of decades, the lifespan of patients with kidney disease has improved considerably. Uh, Even in India, it has more than double as compared to what a patient with kidney disease had in the 1970s or the 80s. So it's a matter of time before further progress is made. And from our side, we should make sure that any patient who is prone to kidney disease like diabetes, hypertension, or any other chronic disease, they should make sure that they avoid painkillers, they routinely monitor renal functions, and contact a general physician or a nephrologist at the first possible time, so that proper management can be done and progression to kidney disease is stopped.
And on that note, I'd like to thank you, Dr. Arun, for joining us and for sparing your valuable time and educating us. And with that, friends, this is a wrap of this edition of Let's Talk Health. We'll be back with more interesting episodes. Until then, keep that mask up, stay safe, and thank you for watching. Namaskar.